practical summer series tonight. We've got two. We've got Dr. Bagwell that has opened a practice kind of on the south side of town, and he's going to actually talk about that. So I'm going to let him kind of talk a little bit more about that and introduce himself, and I think kind of even the philosophy of how the clinic works. Am I right about that? Or okay, good. Right about that. So he's going to get up and talk about that for a few minutes, and then we're going to turn it over to Robert. Robert's kind of one of ours. He interned with me one summer. I baptized Robert when he was 16. Is that right? So Robert's got kind of a special place in our heart, and they're going to actually talk about kind of the trajectory of the pandemic, so some best practices, and even help us kind of be able to navigate all the different information that's going on right now. So if you will, let's just take a second and welcome them here, if you don't mind. And a couple more things, and then I'll say a prayer. If you've got questions, okay, Robert may have some time for questions at the end, so if you have them, make sure that you raise your hand, and what I'll do is hear your question, then I'll repeat it into the microphone after you ask it, so our people at home will be able to hear it, because if you just ask it, then they'll be lost. And also, those of you that are on home viewing, you can actually type your question. If you go to Facebook Live, you can type your question under the streaming, and Robert has graciously told us that even if he doesn't get to them tonight, he'll try to get to some of them later if he can't answer all of our questions tonight. Or you can shoot me a text message. Now that demands that you already have my number in your phone, so if you don't, that's actually double protection, right? It's protection for you, because we thought about running my cell phone on the bottom. I thought, that's a terrible idea. We're not going to do that for this. But if you got my number, you can shoot me a text message and I'll ask your question. So right now we're going to pray, and then we're going to turn it over to Dr. Bagwell, and then he'll turn it over to Robert. Let's pray. Creator God, we are just so thankful for this time together. Just thankful for the ways that you bless us and gift us. That you gift us through the power of your Holy Spirit, but you also gift us by giving us different gifts that we use in the world, whether the gift that we have is relational, whether we're good builders, or we're good teachers, or maybe we're a good mechanic, or we're good at painting. You just give us these different gifts, and we're thankful that we have these two men that are gifted in medicine tonight, and that you have used them, and that they bless people through both the spiritual connection, spiritual relationship that they have with you, and also the medical relationship that they have with their patients through your gifting. We love you, Lord, and we thank you, and I pray that tonight you will just help us to learn a little bit, draw a little bit closer to you, and realize how we can navigate these difficult times with a little bit more grace. We love you, and in Jesus' name I pray. Amen.
All right, Pastor Grant, thank you for inviting us to speak. Dr. Barnes, thank you for asking me to come and join you. I think I've met some of you guys before through the clinic, and for those who've not met me, we'd be happy to meet you after the service this evening. I've got the easy part tonight. Dr. Barnes is going to have the hard part. He's got a lot of slides we're going to go through. But basically, we've got two real agendas. The first part is just to review a little bit about who I am and about our clinic. And that's kind of exciting to talk about because that's easy. I know that part. And he's going to review all the COVID slides. So first, who am I? Well, I like to say I'm just a country boy. I was born in Mississippi, grew up in around Flowood, Pearl, Brandon, and I always list at least 3 or 4 cities because my dad was a fireman. And if any of you guys here are in fire departments, you know that we have at least they have at least 3 or 4 other jobs. So he grew up building houses, and so we moved quite a bit. We may own 3 or 4 different houses in one subdivision because we'd build a house and move. And oh, you can hear me now. Excellent. And so anyway, I was telling the story of my dad was a fireman, and where I grew up, I always list at least 3 different cities because we moved a lot. We'd build a house and turn around, sell it, and move again. That's where I grew up, and then I had great parents, honorable parents. They weren't Christians, though. At least they weren't at that time. And I have an uncle who I owe a tremendous amount to. Anything that I've ever made of myself, I owe to him. He was a pastor. He was a Sins of God pastor. And I remember he used to take me, whenever I was a little bitty, to this, what used to be like Boy Scouts. We called it Royal Rangers in the Sins of God. and he put a lot of scripture into my heart. He mentored me greatly. And I remember when I was in the 8th grade, I began having dreams about the world would come to an end, and I knew that I wasn't ready if the Lord were. Southern thing to do. So I asked my mom, I said, why don't we start going to church with our uncle? It was her brother. And so she took me to church that morning, and I'll never forget it. That's the day that I became a Christian in the 8th grade. And then we went back to church that evening, and then my mom gave her heart to the Lord. And she's continuing to serve the Lord today in her local church. So that's where I grew up, Flowood, Mississippi, just a country boy who happened to have lots of interest. And so as I got out of high school, I began to pursue some of those. Initially, I was quite naive. Not becoming a Christian to the 8th grade, I thought that I wanted the good Lord to use me for something. And being naive, I thought that meant I needed to be a pastor. And so I actually went to Bible college in one of these Assemblies of God schools up in Springfield, Missouri. And I began to study theology. I was going to PhD in philosophy, theology, teach, take an academic position somewhere, pastor, do all those kind of things, and it never really felt fully right for me. I always had an interest in science and math and physics, and I always was naturally gifted in that, not so much in public speaking, you may notice. And so go back into the time. Now, this was in the late 90s. The whole Word of Faith movement was going on, and I won't get into doctrine much tonight. But that time was the name it and claim it type of stuff. And so many times people were thinking about, if God was going to bless you, just, pray for a big house or a big car or whatever, and he would give you what you meant and what you were wanting. But there was a sermon I heard, and it said a little phrase off of that. It says, maybe those things that make you who you are, those things that make you are, those interests that you have, those God-given talents that you have, maybe that is what God wants to do with your life. And so to me, it was math, it was science, it was medicine. And so I began to pursue that and ended up going to pharmacy school at Ole Miss. And because I had one sibling who's a pharmacist, and my family wanted me to follow in his footsteps. But after graduating pharmacy school, I realized, I didn't want to do that for a living. And so I went on to medical school up in Kansas City, and then I came and did my residency in Tupelo. And stayed with North Mississippi Medical Center for about 10 years, left there and went and joined a practice in South Haven. Had a wonderful time there, but after about 5 or 6 years, I don't know whether I was having a bad day or if it was a God thing, but I felt like I was going to do something different. Left that clinic, and I came down here to start my own clinic. And we were really blessed with that. And there's a scripture that talks about how God orders the footsteps of a righteous man. You guys believe that tonight? And I stand here today, and I can tell you that that's the truth, absolute truth. It's interesting sometimes when you get to be middle-aged now, like I am, and looking back over your life, of how you can see where God put people in your life that wasn't an accident. You don't know it at the time, but you look back and you can tell that. Many things took place to make our clinic successful. He's part of that. When Robert was in his second year of medical school, he came to the clinic I was working at, and he was just doing a summer job. He was working on creating a new, what we call an electronic medical record, that little computer system that we run around on our laptops and work on. And I've always had interest in teaching, so we began to make small talk. And I'd have an interesting case. I'd say, "Hey, Robert, you want to come look at this case? And here's something interesting." And we would, stay after clinic, and we'd talk about this and talk about that. And then we had just really a small relationship start from there. And then he actually came back as a third-year medical student, did a rotation, and then a fourth-year medical student, and did a rotation with me. And so we kind of sort of hit it off, and now I can look back and say, you know what, that wasn't coincidence. I'm absolutely convinced the good Lord put him there that summer so that we would be here today. And that's one of the things where I can say, footsteps of a righteous man are ordered. He was supposed to be there. That's destiny. That's destiny. There's another guy, you guys probably know, Dr. Sneed. He's a cardiologist from this particular area. Whenever I was in South Haven, he would begin to send patients to me. Many of you guys may have seen me even whenever I was in South Haven, and he would send them to me. Little did I know, all those patients that he was sending to me happened to be from down here, because he was from down here. And so many of those people were influential down here, and whenever I left my South Haven clinic to move here, they were the people that was established here and was sending us patients. And that was a God thing. Again, the footsteps of a righteous man are ordered. And so that's amazing of how that took place. The last little thing I want to share before we get to the real meat of the topic tonight with coronavirus is a scripture. Let me log into my scripture here. If you've got your Bibles with you, look at 1 Peter 5:2. 1 Peter 5:2. For those who've ever seen us, if you get your bill, you'll see on top of that bill, archipoimen. That's a Greek word. The actual name of Bagwell Medical Clinic is Archipoimen, PLLC, doing business as Bagwell Medical Clinic. Archipoimen comes from 1 Peter 5:2, verses 2 through 4. Let's read that here. That says, be shepherds of God's flock that's under your care, watching over them, not because you must, but because you're willing, as God wants you to be, not pursuing dishonest gain, but eager to serve, not lording it over those entrusted to you, but being examples to the flock. And when the chief shepherd, capital C, capital S, appears, you will receive the crown of glory that will never fade away. The Greek word there for chief shepherd is actually archipoimen. And at the end of the day, I view that the good Lord is the chief shepherd. And he's given some of us talent to take care of sheep. And so he's the chief shepherd. I'm the little shepherd. Dr. Barnes is the little shepherd. And we're called to do something, not because we must, but because we're willing. And so hopefully, one day, we'll receive our crown of glory that will never fade away in regards to that. So that's a little bit about who I am, where I came from, and how I got here, the quick, short version of that. That's a little bit about our mission and what we do and why we serve. And if you call, you'll hear our message, Serving with a Shepherd's Heart. That's where that came from. If you look at our logo, you'll see a cross and with two different colors. And in those colors, the separation's made by a shepherd's hook. And it's because he's the chief shepherd, we're the little shepherd, who's called to serve his people. And tonight we're going to serve by giving you an update on COVID. I know this has got people panicked, anxious, nervous. And we're going to try and provide peace. At the end of the day, the good Lord is the Prince of Peace. And so we're going to review some of those information today. We're going to spend time afterwards asking questions. So write your questions down. We're happy to review them as long as we can and give you the best answers that we can. Okay? I'm going to pass this to Dr. Barnes and let him start his presentation. And I look forward to seeing some questions from you guys or meeting you after service. All right?
All right, thank you so much, Dr. Bagwell. All right, I'm not sure what that is. Am I doing something wrong? Okay. Okay. Thank you so much for that introduction, and it's definitely a blessing to be a part of something like that, where it's not only just a job, but it's a it's something more to that. It's deeper. It's being able to serve others through that. I'm very honored to give you an update on some of this stuff. I spent a lot of time compiling a lot of this information together. I'm going to try and give you about 8 years of education in the next 30 minutes or 40 minutes. So this is kind of how things will go. We've gotten through the introduction part, heard about Dr. Bagwell in the clinic. You pretty much know about me, so I won't go too much into that. I pulled some of this stuff off of the Mississippi Health Department Facebook page that gives us a status as of from July 21st to August 17th, as you can see at the top. This is a breakdown essentially of vaccinated versus unvaccinated patients in Mississippi. Right now, what we are seeing is that unvaccinated cases in Mississippi account for 98% of all cases. If you go further into hospitalizations, this middle chart, 89% of hospitalizations are unvaccinated, 11% are vaccinated patients. And then when we look at deaths in Mississippi, during about the last month, 86% have been unvaccinated, and then 14% have been fully vaccinated. And one of the things that's interesting, and I think a lot of people get confused, is how is 2% of cases adding up to this much mortality? And the answer is the people that have mostly gotten vaccinated in Mississippi are those people that are higher risk. If you think about it, when we rolled out the vaccine, the people who got the vaccine first were higher risk, older than 65. And you can see that in Mississippi, 72% of patients, or 72% of people older than 65 are vaccinated, whereas the overall in Mississippi is only 38%. And that is much lower than the national average that is 52% of the total population. So a lot of those people that are being hospitalized despite vaccination, we're talking about people that includes 90-year-olds, 80-year-olds, people with underlying COPD. Those are the ones that, statistically speaking, are more likely to have been vaccinated. And this is another chart that came out a little while ago, early August, and it was showing an interesting trend. And that is, in the month of August, we started to see a different age group take the lead as far as number of deaths by age group. Previously, and all throughout the pandemic, it has been the 65 and older age group. But you can see this yellow line here where it crosses. This is the age group 50 to 64. And this is the first time in the pandemic that we've seen more deaths in that age group, despite being younger. Remember, we're including in the 65 and older 70, 80-year-olds, 90-year-olds. And so a lot of that has to do with vaccination status. You can see 42% of the deaths in August so far, or at least at the time that this was released, was in that age group 50 to 64, and then 38.7 was 65 and older. So I want to stop real quick and do a little brief history, because we're in a very similar situation to 1918, the Spanish influenza. Previously, it was one of those cited as being the worst viral pandemic in the United States. And it still is worldwide, obviously. It killed 50 million people worldwide when it happened. In the United States, at that time, the population was 102 million. Right now, it's about 300 million, or 320 million. It killed 675,000 people in the United States. And so the question is, how did it kill so many people? Well, one way is supplemental oxygen, which is what we give all the time in the hospital, was just beginning to be explored. If you know someone who's been hospitalized for COVID, more than likely their criteria for admission to the hospital was that they needed oxygen. This was in its very, very primitive state in 1918. Mechanical ventilation did not exist, okay? They did not invent the first crude ventilator until 1928. I believe in the polio epidemic in the 50s, we're still using iron lungs, okay? And then lastly, antibiotics did not exist. Penicillin was not invented until 1928. So all that being said, a lot of people died largely because they didn't have supplemental oxygen, they didn't have ventilators, and they didn't have antibiotics. One of the things to note about the antibiotics is that one of the ways that the influenza virus kills is it sets you up for a bacterial infection. There have been some claims that really it wasn't that much more deadly of a virus. It just had to do with a lot of crowding of hospitals and stuff, that so many people got sick, and then bacterial infection is what caused a lot of those people to die, okay? So here's where we are in total deaths in the United States. 629,891, and this is a few days old. So that's how many people have died in the United States, despite huge advancements in supplemental oxygen. We can give oxygen through a nasal cannula, through a mask, through a high-flow nasal cannula. It is very advanced. We can titrate the exact flow rate, the exact percentage of oxygen that we give. That is despite having very advanced ventilators and a lot of research in ventilator use and how to use it safely without causing lung damage. That is despite having antibiotics. And in fact, COVID doesn't really rely on bacterial superinfection to kill people. Most people who do die of COVID die of the virus, not of a bacterial infection. So imagine if it was 1918. I like to think, a lot of people underestimate the severity of the COVID, SARS-CoV-2 virus. But the reality is, if every person that has needed oxygen or a ventilator, they would have died if it was 1918, essentially. If every one of those people that needed it during this pandemic did not have it, they probably would not be alive today. Those numbers would be very different. So here are our current outpatient therapies. I won't talk much about inpatient therapies like the ventilators or the oxygen delivery and stuff like that, because that would become relevant more so if you were hospitalized, and we're going to try and prevent that. The first thing I'll talk about is vaccines. Next, I'll talk about monoclonal antibodies. So the goal, essentially, in our understanding, has been to combat a virus. What we need is an antibody response. So if you don't know about antibodies, they're essentially these proteins in your body that your immune system makes. It latches on to harmful things such as a bacteria or a virus, and then that marks them to be gobbled up essentially by your immune cells. And this is a little off topic, but it sets me up for the next slide, okay? And that is what we consider a successful therapeutic in medicine. This is a study in JAMA about the benefits and risks of low-dose aspirin. You probably know people on aspirin. If you've ever had a heart attack or a stroke, you're most definitely on aspirin unless there's some other reason why your doctor thinks you can't have it. This study, and I have this red box here, it basically breaks down the benefits and the harms of being on aspirin. So aspirin reduces all-cause mortality by 18%, reduces your chance of having another stroke by 20%, reduces your chances of having a heart attack by 30%. However, aspirin also increases your risk of GI bleeding by 2.5 times compared to placebo. So it's a 250% increased risk of having a GI bleed, 250%. All to achieve an 18% decrease in mortality and a 20 to 30% decreased chance of having a heart attack or a stroke. So, but it is considered so successful, it is such a benefit to be on the aspirin to prevent those things that it is worth taking the risk to be on that, even if it is a risk of GI bleeding of 250%, okay? And it is such common practice and so recommended that it would be malpractice not to recommend that to a patient who's had a stroke or a heart attack. That's to give you an idea of what we consider a successful therapeutic and the risks and benefits we take. Here are the vaccines that are recommended. Pfizer is now FDA approved. It is 95% effective at preventing laboratory-confirmed COVID infection. If you get COVID, it is 90% effective in preventing you from having severe COVID. Similarly, Moderna is also a 2-shot series, an mRNA vaccine, 94.1%, very similar. Johnson & Johnson is a 1-shot vaccine. It's less effective. That's not surprising. It's actually pretty impressive that it has as good effectiveness as it does, given the fact that it is a 1-shot vaccine. Here are the common side effects: pain, redness, swelling at the injection site, and then tiredness, headache, muscle pain, chills, fever, and nausea. All of these symptoms are essentially symptoms that your immune system is revved up, one way that we keep track of vaccine side effects is through this thing called the Vaccine Adverse Event Reporting System. And so I want to give you a little idea. You'll hear a lot of things about different side effects that come from the vaccine, and where does this come from? How do we know? Basically what it is, it's a national vaccine safety surveillance program, and it helps us detect unusual or unexplained things. Anybody can, if they've had the vaccine, anybody actually can report to this. So actually it doesn't matter if they've had the vaccine. If you know someone, if your family member had a reaction to the vaccine, if your cousin had a reaction to the vaccine, you can report a vaccine side effect. It accepts the reports from anyone. It relies on people that sends in their experiences, though. Healthcare providers and vaccine manufacturers are required by law to report any side effects that we know about. It is not designed to determine if the vaccine caused it. And that is just simply because sometimes things happen and people think back, hey, I got the vaccine a week ago. It's good that we report it. It's good that we keep an eye on those kind of things, but it doesn't necessarily demonstrate a cause and an effect. And I'll give you some examples. If we do see a pattern, though, follow-up studies are done to make sure the vaccine is not causing harm. So I looked through the vaccine, the VAERS system, and there's a lot of things that people report is because of their vaccine. Things like obesity, things like depression. I was looking for the statistic death, and I actually saw below that someone had reported the death of their pet because they had gotten the vaccine. Homosexuality and homelessness, not generally something I think about as a side effect of the vaccine, but I guess it's good that we report this. So that's just to give you an idea. And here, I skipped this slide. This is just in the D and E portion. This list is extensive, and you can see how many people report it. And it's good. It's good that we have this data, but it definitely has to be looked into, and you can't take it at face value, or else you'll think that your pet may die if you get the vaccine, if you don't interpret that data rationally. So here are some of the rare adverse reactions that we've kind of seen and we know about. One of them is called anaphylaxis. It's an allergic reaction to some component of the vaccine. It's very rare. It's just like someone who has an allergic reaction to seafood or something like that. It's treated with epinephrine. The rate of occurrence is about 1 in 200,000, or 0.0005%. This is all straight from the CDC's website. Myocarditis and pericarditis. I'm sure you've heard about that. I've seen Facebook posts about this. I've seen the picture of a young girl who is a very sad story about what she went through, and is not great if you're that person. Fortunately, she is smiling in the picture and doing well, which is actually what happens to most of these patients. Myocarditis and pericarditis is basically when you get an inflammatory response around the heart or towards the heart muscle. And then cause some chest pain, shortness of breath. It actually is a little more common in younger people who get the vaccine. It's associated only with the mRNA vaccines. And those people do well if we give them anti-inflammatories, like some of the drugs that are used, like naproxen or something like that. The rate of occurrence is 1 in 278,000, or 0.00036%, straight from the CDC website. This is another adverse reaction. I'm sure you've heard blood clots are happening in some people. This is associated with the Johnson & Johnson vaccine only. That's the one-step shot. It is a very deadly thing if it happens. 22% of people die if they get this. Fortunately, the rate of occurrence is only 1 in 309,000 of the Johnson & Johnson vaccines, okay? Not including the Pfizer vaccines, obviously, because they're not, or Pfizer or Moderna, because it's not one that's causing it. But it's very rare, 0.00032%. So before we proceed, I've already talked about VAERS. I've talked about how, right now we don't have an exact number of, deaths attributed to the vaccine. In Mississippi, there's none confirmed. I don't really know of any confirmed deaths to the vaccine, to my knowledge, right now. So before I proceed, what I'm going to give you is the number of this. If we trusted VAERS, and that is every single report, no matter whether or not it's been validated, I'll give you the number of the highest that the death toll could possibly be, understanding that it is likely much, much, much lower. But keep this in mind before we proceed. Someone dies every 12 seconds in the United States. Every 12 seconds. That's 5 people every minute. Someone has a heart attack every 40 seconds. Someone has a stroke every 40 seconds. Someone has a deadly, a lethal blood clot. That is, they die of a blood clot called a pulmonary embolism every 6 minutes. And so if anyone dies after any one of the 365 million COVID vaccines that have been given, if you know someone that dies afterwards, you're going to report it, as you should. But keep in mind, statistically speaking, with all of these deaths and incidences occurring, it's highly likely that someone's going to have their heart attack after their vaccine. It's just going to happen. I think there's a slide in there. Oh, here we go. Actually, it skipped over it. So this is where I'm going to talk about death. We fully vaccinated over 171 million people. There have been over 365 million doses given. In total, there have been 6,789 reports of death to VAERS, which have, again, not been confirmed. But even if I state that all those deaths were caused by the vaccine, that would mean that 1 in 111,000 people have died, or 0.0019%. That means that the COVID infection is 1,000 times more likely to kill you than the vaccine. And that's largely, actually, probably 10,000 or 100,000 times more likely to kill you than the vaccine. It has a 1.9% fatality rate. So again, things more likely than side effects from the COVID vaccination. Maternal death during childbirth in the United States. I'm not talking about third world countries. This is in the United States. 1 in 5,747. Being struck by lightning in your lifetime. 1 in 15,000 people will be struck by lightning during their lifetime. Deaths to surgical anesthesia for any procedure. 1 in 185,000. And then lastly, the average Mississippian dying of COVID, from COVID, if they catch it. 1 in 51, nearly 2%. Again, I understand if you're younger, that number, you got to understand your rate of death will be lower. If you're older, have more comorbidities, that number will actually be higher. Okay. So let's talk about some of the acute COVID complications, so things that happen if you get COVID or can happen if you get COVID and while you're actively sick. Mechanical ventilation, that happens at a rate of 12 to 24%. Myocardial injury, that is injury to the heart, that is measured by what we call troponin elevation. So that's a lab we check to determine if it's an enzyme that's inside of the muscle of the heart and it leaks out during muscle injury. So that happens in 7 to 36% of patients. For all the talk about the concern about the heart-related effects of the COVID vaccine, remember that happened in about 1 in 200-something thousand. This happens in 7 to 36% of COVID infections. Blood clots, particularly in ICU patients, I'm pretty sure this is data in ICU patients, 10 to 40%. But we know that you do have some risk even if you don't go to the ICU. Encephalopathy, 33%. Long-term symptoms are on the next slide, and this is what I'm seeing a lot of in clinic. People who have had COVID and then have these persistent symptoms of fatigue, dyspnea, also called shortness of breath, chest discomfort, cough. Anosmia is loss of smell. These range anywhere from the teens up to close to 90% for fatigue, and they may last 2 to 3 months. Another important thing is this impaired memory and poor concentration. People typically have this in the rate of the teens as far as percentages go and can last for weeks to months. And there's really not much you can do for it other than kind of live with it. Again, I already mentioned this, Pfizer COVID vaccine is now fully approved by the FDA. I know a lot of people were waiting for that. And here's a little humor to kind of lighten things up. This is a post by, I'm assuming some MD, I actually don't know who that is, but I thought it was funny. But 94 to 96% of physicians are vaccinated. So assuming the vaccine was made to kill the population, why on earth would the government want someone that owes $250,000 in debt to be dead? And that's true. The AMA has done a survey. Over 96% of doctors are fully vaccinated against COVID. That was June 11th. I'm hoping that number is higher now, honestly. I'm surprised it wasn't higher at the time. There are some people, you may hear about some physicians that are out there, they go viral usually when they do this kind of thing, but may not recommend the vaccine. The Federation of State Medical Boards has actually appealed to Washington, D.C. on July 29th, 2021, basically saying that they want people that spread vaccine misinformation, if they're a doctor, to get some kind of warning or some kind of, something like that, possibly be reprimanded for spreading vaccine disinformation that goes against, basically, they're against their board, whether that's ACOG, the American College of Obstetrics and Gynecologists, if that's the Infectious Disease Society, if that's American Academy of Family Physicians, if that's my board, the American Board of Internal Medicine, or the American College of Physicians. If I go against my board, as a general rule, if your doctor does that, especially with something like this, you should be concerned, because a lot of really smart people have looked at this, and this is definitely something that is on the horizon. So here's kind of a segue into my next therapeutic. I talked about vaccines. The FDA authorized Regeneron's COVID treatment taken by Trump for emergency use. That was back in November of 2020. That was the IV infusion of Regeneron's monoclonal antibody. Trump got this when he was sick with COVID, actually, and he actually sang its praises at the time, if you remember some of the news reports. Again, a monoclonal antibody, what it is it's a synthetically engineered antibody. It's made in a lab, and it is targeted to attach to the virus, specifically the spike protein of the virus. And by doing that, it really messes with the virus's ability to enter the cells, to replicate, and also marks it somewhat for being gobbled up by your immune system, essentially. Here is another news report or study that came out. The phase 3 trial data for a monoclonal antibody called casirivimab and imdevimab. Those are very hard to say. I practiced for a while to get that right. RegenCov2 is the brand name. It's approved for subcutaneous use, and this has really helped out a lot of primary care doctors that don't have an infusion center or access to a center of excellence in Mississippi where they can do the IV stuff. It's given basically like insulin is into a fatty or a fat-bearing area. You get 4 injections, and it's really effective. Here's some of the data. It significantly shortens the duration of symptoms by 4 days. It is the only monoclonal antibody treatment that has retained potency against the emerging variants. And this is the most impressive statistic here. It reduced the risk of hospitalization or death by 70% compared to placebo. And that's based on their phase 3 trial data. There are different indications for monoclonal antibody therapy. There's been some approval for post-exposure prophylaxis in vulnerable persons who are not fully vaccinated or immunocompromised. And then those who are actively infected have really been who we've been targeting in our clinic. And those people, if they have risk factors, a lot of them like obesity, diabetes, high blood pressure, cardiovascular disease, and there's a big list. It's very easy to qualify, though, and it's very beneficial. The adverse effects to it are local injection site reactions, nausea and vomiting, And then with any injection, generally there's going to be somebody who's at risk for anaphylaxis. So after you get the injections, you're monitored for an hour because that's when most anaphylaxis reactions occur. And should that happen, you're given epinephrine. There have been some reports of greater than 24 hours after administration, but again, that's why it's a good idea to tell patients, hey, keep an eye on your symptoms. If you have any changes, go to the ER. Now I'm going to go to the part that probably a lot of people have been anticipating, and that is some of the myths that you're hearing from other people, and then what I would say about it in response. One very common myth is that the vaccine causes infertility. This is the facts. According to the CDC, there's no evidence that COVID-19 vaccination causes any problems with pregnancy, including the development of the placenta. In addition, there's no evidence that female or male fertility problems are a side effect of the vaccine, including the COVID vaccines. Furthermore, as I mentioned before, it's important to look at what the people who are in these big organizations recommend, and that is the American College of Obstetrics and Gynecology. And in fact, I don't remember the exact abbreviation, but I think it's the Maternal Fetal Medicine Society. They also stand firmly with the recommendation to give COVID vaccination to individuals who are pregnant or planning pregnancy. And that is because of, unfortunately, what we've seen recently. I hear this from a lot of my hospitalists and critical care colleagues. They've dealt with some of these patients on the ventilator that have had to get C-sections while in the ICU. Okay, they have seen at the University of Mississippi a mother who lost her life to COVID shortly after a C-section, and who had also infected her husband, or her husband had acquired the infection by whoever knows how. But they both died, and the child was actually transferred to UAB to be kept there in the NICU. It is harmful to fetuses. As of June 14th, 124,600 pregnant females had received the vaccine. I know that's a little dated. The CDC followed over 5,000 pregnant women who were vaccinated during pregnancy, and the result is as followed. There were no unexpected pregnancy or infant outcomes due to the vaccine. 86.1% of pregnancies resulted in live birth, while 13.9% resulted in pregnancy loss. And unfortunately, I was actually kind of surprised it was that high, but that's the typical rate of miscarriages and stillbirths, actually. It alters my DNA. And the fact is that mRNA is a molecule that we make with our DNA. It does not go backwards. RNA can never become the DNA. It's not how the process works. And it is made by a process called transcription. It is then read by enzymes in the cell and another part of the cell that make a protein based on what that mRNA codes for. It cannot enter the nucleus or affect the DNA at all. It's also very unstable, and it degrades really quickly at room temperature, which is why until it's distributed for use by a provider who can then refrigerate it and keep it for about a month or so, it has to be frozen at negative 100 degrees Fahrenheit. So this is kind of what I was describing. This is DNA. It's a double helix thing, if you remember anything from the biology classes and stuff. And the way we use DNA is we use special enzymes that use the DNA to make our RNA, and then RNA travels out to the rest of the cell, and then it is used to make what's called a polypeptide, which folds up into a protein. And that protein is then, it has actually essentially a postmark on it, or where it's supposed to go in the cell within its sequence. Really cool stuff. So the vaccine was rushed is another thing I hear a lot of. Two components of the vaccine that are pretty advanced technology. The lipid nanoparticles, that's what we are putting the mRNA component of the vaccine in. Those were first combined for the purposes of experimentation in mice in 1989. In 2000, the first drug was approved using the lipid nanoparticles to deliver that drug, verteporfin, for the treatment of macular degeneration. I'll speak no further on that. That's Dr. Scott's level of expertise. In 2017, we first started using in-human tests of personalized mRNA cancer vaccines. This was very exciting, and I actually hope that aspect of mRNA technology continues to advance. The same idea, I assume, applies. They take a piece of the cancer, they find a protein that's on that cancer cell that's unique to your cancer cell, and then what they're able to do, due to the ease it is to make a vaccine this way, is they use it to make an mRNA to make a protein that was on that cancer. So you could make a specific cancer therapy for each person, not just for, you have this type of cancer, and so we'll treat everyone in the population with that. And so if we were ever wanting to adopt personalized cancer therapy, mRNA is one of those things that was going to open up that door. Here is another example of us. We were talking about this. This is in Nature Review's website. mRNA vaccines, a new era in vaccinology. This came out in 2018. So this was something that was on the horizon. We were very excited about this. The biggest thing about it that was appealed to us is the ability to actually spin out and turn out a vaccine quickly. That was the key here. And so this came around at the right time for us, and we're very, very lucky for that. We don't know the long-term side effects. That's one that I see a lot. The mRNA component of the vaccine, as I said, is very unstable. It degrades within 72 hours of injection. The lipid nanoparticles leave within days. And one fact is that in the history of vaccines, long-term side effects have only popped up in the first 2 months. We are now over a year from the beginning of the phase 3 trials for the Pfizer vaccine. Should there have been, or if there were to be, long-term side effects of the COVID vaccines, primarily with the Pfizer vaccine, we're now over a year out. Okay, so we would have started to see any one of those 40,000 people start to have something pop up. So if you were not wanting to be a guinea pig, if you got the vaccine now, you would not be. Okay. The other thing is, I did mention 357 million people in the United States have gotten this. I've had COVID, so I don't need the vaccine. I can sympathize definitely with that argument. It makes sense. Okay, if you have antibodies, a lot of people come in and they want testing for antibodies, and it makes sense. If I have antibodies, why do I need the vaccine? And the problem is, we may detect the antibodies. We don't know how well or how long that natural immunity lasts or how effective it is against the variants. Different people have different severity of disease, and then we'll have different immune responses based on the severity of the disease. And so if I checked your antibodies today, I don't know if in a month you'll still have them or not. It's much easier to have a standard exposure and know, hey, we're starting to lose some effect of the vaccine. We can anticipate that probably everyone in the population is probably losing effect too. Hey, maybe it's time for a booster. And then the next thing is, natural immunity is somewhat messy. It's not as focused as the immunity granted by the vaccine. And this kind of ties into sort of another argument I've heard. I've heard, why not let this just spread through the community, right? Let's just let everybody get exposed, let it do its thing, and let our natural immune system take care of it. And the argument against that, because it made sense to me when I heard that too, I'm like, let's just isolate the people who are older and who are at risk, and let's let all the young people get it, and then maybe we'll get some herd immunity out of that. Makes sense, right? No disease in human history has wiped itself out with herd immunity, ever. But we have. We have done that. We have eradicated smallpox. We have eradicated polio in the modern world using vaccines. If the vaccine works, why do I need a booster? This is another thing I've heard, and we were very excited about the 95% efficacy when the trial data came out. But I want you to know that initial trial, the initial two-step vaccine series that occurred over a short period of 3 to 4 weeks, was implemented for a specific reason. We were having a lot of deaths, and we needed a vaccine to finish the trials quickly, and we needed to know that it would work. So in order to get that 95% efficacy as soon as possible, it was a shorter series, essentially. It was a quicker series. Knowing that in the past, every time we've had to give booster doses, it's generally spaced out 6 to 8 months. If you think about it, you get your Tdap shot every 10 years. When you were a kid, you got it, every year or so apart. You had your measles and mumps shots. You had to get multiple shots, usually spaced out by a year or so, or maybe 8 months. Your pneumonia vaccine, a lot of you probably remember that. You have to space those out. So it only made sense that, we were optimistic that this effectiveness would last, but it's not surprising that a booster is required. We did not have the luxury of time. If we had tried to do a trial where we'll give you your first vaccine, see you in 6 months, we'll give you your next vaccine then, and then in a few months we'll look at the data and see if you ended up getting COVID. That would have at least taken 8 months to do. We didn't have the luxury of time to wait for that kind of data. So again, most of the vaccines we get lasting effectiveness with boosters given at 6 to 8 months. This is just to illustrate what I was talking about. This is DTaP we give to kids, 2 months, 4 months, 6 months. Pneumococcal, we give it, spaced out by several months, or a month at least. Some of these others, hepatitis A, spaced out by 6 months. And the list goes on and on. Meningococcus, we give multiple doses spaced out by a significant amount of time. And this is another one. It's been very, very controversial. Even among doctors, this one's been very controversial. So what is ivermectin? I'm sure you've heard about people buying ivermectin at the co-op or getting a vet. I don't know if they get it from a vet or something, or sometimes they get it from their doctor, which is something that happens. It's an antiparasitic drug. It's used to treat various human and animal parasites, and it acts as basically a neurotoxin to those parasites. Thankfully, it doesn't cross the blood-brain barrier, and so therefore we don't get neuro side effects due to it at appropriate doses. In vitro, that is, and this is where all of this whole idea that ivermectin could treat COVID came about. Someone said, hey, let's take this old drug that's been sitting on the shelf, and for whatever reason decided to get a petri dish with COVID and basically put ivermectin in certain concentrations into that petri dish. And they said, hey, if we get it to this concentration, then we can inhibit it or stop the reproduction of COVID virus. The problem with that is the concentration of the medicine that you needed, you would have to dose it at 50 times to 100 times higher than what is used to treat parasites. And so we don't even know. It's FDA approved and it's safe in the doses that we use for treating parasites. But based on this mechanism, at least, based on this data, it should not work to treat COVID. We don't have high enough doses. There was a big study that came out in, I believe it was June, and it's a meta-analysis. And what that is a collection of smaller studies, and it helps us basically to increase the viability of the evidence that we see. It's by Andrew Hill and his colleagues, and it's gotten a lot of attention, especially from doctors that have looked at this, and some people have jumped on the bandwagon about this. Some of the studies in that collection, and that's one thing I want to note, your collection of studies is only as good as the studies you put in it. None of these studies came out of the United States. Many came from Egypt, Bangladesh, Iran, and some other countries. The problem is most of those studies are not peer-reviewed, and they're preprint studies, and they're released before we've had time to look at them and critique them and say, hey, there's a flaw in your analysis. Two come to mind that are very important. They give this big meta-analysis all of its power, essentially, or most of it. The most impactful ones are this Iranian study and an Egyptian study. The Egyptian study has actually, and this is very brand new as of early August, it was actually withdrawn from the meta-analysis. And that's because someone peer-reviewed it. And they found that there were errors like I think someone's date of death was before the study started. I think there were several patient demographics, that is, characteristics about the patients that looked like they were copied and pasted, like several similar things that should not have added up. And there have been other things with some of the other studies that made it look like basically the study was not conducted properly. The last thing, the myth I'll talk about, is that masks don't work. Actually, in epidemiologic studies, government-issued mask mandates, I know that's a controversial topic, but statistically speaking, and high rates of self-reported mask wearing, both of those have been associated with decreased community incidence rates and, in some cases, decreased COVID hospitalizations. So we have seen that. Mask wearing in the community may also be associated with protection for the wearer, and then has also been hypothesized to reduce the viral inoculum. That is, if you do get sick with COVID, maybe you got less of the virus and you won't get as sick. This is a really funny picture here, and I kind of got a point, I guess. Smoke inhalation, we wear this mask. For painting, we wear this mask. Radioactive material, we wear this. And then they say the deadliest virus in history, and you got this little tiny piece of cloth. It's funny, I get it. Let's talk about the filtration efficacy of different masks, okay? A lot of people say mask is stupid, right? A virus is super, super tiny. It will go straight through the holes in a mask. That fails to account for the fact that these viruses, they basically are collected in droplets. That's how they're transmitted. So if you can prevent the passage of the droplet, that is about 0.3 micrometers in size usually, or actually 0.5 to 0.2 micrometers, 0.5 to 20 micrometers, then you can effectively prevent infection. It's kind of like, you may have a water-resistant pants, for instance. The water droplet kind of rolls off, doesn't go through as easily. It doesn't mean that the pants fibers are so closely knit that it's not allowing the passage of a water molecule. It just means that water droplets didn't pass through because they form a droplet and then they'll roll off. So let's talk about some of the effectiveness. N95 mask, greater than 95% filtration of 0.3 micrometer particles. The medical masks that tie up in the back, like Dr. Bagwell's wearing, and I guess it's interesting because it has 72% effectiveness, whereas the ones with the elastic ear loops are only 38% effectiveness. And I think that probably has to do with how snug of a fit it is. But yes, we do see some decrease, and it is able to filter at least some. And so it can only benefit you to wear it. Okay, this is where I was going to leave some room for questions. I'll do my best to answer those, and if I don't know the answer, I'll be glad to look it up and learn more. Grant will...
There we go. Okay, so I've got a few online questions I'm going to give you. And look, we're already at our time. So if there's anybody here, y'all feel free to filter out. And Robert, I've given Robert all the power, so he can stand up and talk. He may make fun of you as you walk out, but he's got the power to do so as you leave. But he's going to take a few more questions as we've got time. But if anybody needs to go, for real, you guys can go ahead and go. So first, I have... from Marilyn White, her question was, my understanding is that the vaccine is to give you antibodies, but I've heard some vaccinated people did not have any antibodies when tested after getting COVID.
Was that after getting COVID or after getting the COVID vaccine, I'm assuming?
They got the vaccine. I'm guessing after the vaccine, or maybe they would have to be that.
And interestingly enough, we've actually had a patient that requested antibodies. And so, we're happy to oblige if they request antibodies and they're curious. We will test them. And we've had a patient that was fully vaccinated, and then I don't remember how much time had passed, and we tested them, and they didn't have antibodies to the spike protein, which, maybe that's one of the thought process behind why we need the booster. We don't know how long that immunity lasts. We know that we expect it to wane some over time, which is why the booster is being recommended. But I could say from our experience and what we're seeing, obviously there's a decrease in hospitalizations in vaccinated people, and they tend to get less sick from my experience too, not just anecdotally from my experience, but also what we're seeing in Mississippi. So the other thing is, it is probably going to depend on the assay. If it's not at high enough levels, may not detect it, so those levels could drop over time. I don't remember how long that guy it was since he had been vaccinated, Dr. Bagwell.
I'm not sure.
I'll repeat whatever you say.
Yeah, I'm not sure I know that particular individual, but the question really behind the question is, let's try this again. Test. Okay, we're good. So I suppose one would ask, what are we asking behind that question? Okay, let's assume, yeah, sure, perhaps somebody didn't get full immunity after the vaccination. Does that suggest or imply for the 99% that they should not get the vaccine? So the first question I would ask when I would be asked that question is, what are you really asking? And so, sure, there may be one person who doesn't get fully vaccinated, or perhaps that immunity that was provided from the vaccine has worn off. That doesn't justify the 99 that shouldn't, right? So,
and that is a good point too. Again, that question was sort of, they've heard of somebody who didn't have antibodies after. Those things are going to happen. Some people just aren't going to form an immune response. And that's one of the reasons why high vaccination rates are super important, because for most people, we'll get an adequate response. And even if it's slightly inadequate in one person, they will be protected by the herd immunity.
Okay, I've got two more. Rick Walker, who is here, and for some reason wanted to send me a text message, said, is the half-life of the Pfizer vaccine 24 weeks?
The half-life of it. I would say the mRNA degrades in 72 hours, and then the lipid nanoparticles, it degrades in a few days. I think that was on one slide, and that's my knowledge as far as how long it sticks around. Now, the immune response is, generally lasting, much longer than that. Now, maybe the question was on monoclonal antibodies. Now, monoclonal antibodies are the other thing, like the REGEN-COV2. I don't remember the specific half-life. As a general rule, it does drop dramatically after the first 30-ish days, which is one of the reasons why we don't recommend getting the vaccine until about 90 days after you've gotten monoclonal antibodies. And the reason that is because those monoclonal antibodies will basically prevent the vaccine from working right. Instead of your immune system, getting, revved up and making antibodies, this will kind of knock it out before your immune system sees it.
What I was asking was that when you got the Pfizer vaccine, it was 95% effective. And a little report that I saw said that after 24 weeks, it was down to 50%.
That it was down.
Okay. Let me say that through what Rick clarified was that the first reports were that the Pfizer vaccine was 95% effective, and now there are people saying that as time goes on, the vaccine is becoming less effective, even down to 50% in some of the reports. Is that right, Rick?
I haven't heard it as low as 50%. And that's all to be understanding that, the 95% effectiveness was to prevent you from getting COVID that could be detected on a PCR lab test, which is very, very sensitive. So even if that was true and it dropped to 50%, that's still a decrease in your typical risk for infection. And then Furthermore, that does not include the decrease in risk of severe disease. But I have heard there's some drop in effectiveness for the Delta variant, but it's still surprisingly been very effective, based on what we could see based on the hospitalizations. I think that's probably the best data that we can have now.
Okay, I've got one more question, and then we'll go to Sally and some of the questions in the audience. And I've had a few more that have come in. And Robert, you end when you need. I can get these to you. I got his number for anybody that has some more questions that they want to ask. But Rhonda Steele, who adds that she is a patient of both of you, asked, what she said is that she was fully vaccinated, diagnosed with COVID 29th, with COVID on July 29th at your clinic. Her question is, can she get COVID again? What type of immunity does she have? Does she need antibody therapy? Or she might be asking, does she, I guess it is, can she get COVID again? What type of immunity does she have? Do I need antibody therapy? What advice would you give, Ms. Rhonda?
What was the date again?
She was diagnosed with COVID July 29th.
Okay. So generally the recommendation is within 10 days of symptom onset to get monoclonal antibodies. As far as the answer to the question of if you have COVID at any point, it's reasonable, and this is even in the CDC's guidelines, you can get the vaccine at any time after your acute illness has improved. But it's reasonable actually to wait up to 3 months, because it's very, very, very unlikely that you'll get COVID again within 3 months. Now, what I would still recommend is the same recommendations, I believe, is to recommend the booster still once it is time for that.
And if I can clarify with that too a little bit, remember there isn't a such thing as one COVID virus. COVID is like influenza; it mutates, and so when could she get COVID again? Well, it depends on when the next strain of COVID comes around. If she had the original COVID virus, and then you now have the Delta virus available, she could get it quickly. And when's the next one going to be coming around, the next one coming around, those are factors that are unknown. So it makes it a little difficult to, to tell you when you may get the next one or when you may be able to get the next one.
Okay, Sally, you're up.
I'll let Grant repeat the question, I guess.
Yeah. Sally asked, there's a lot of people that do not believe or trust the CDC. Obviously, Dr. Barnes, you do trust the CDC. Dr. Bagwell, you do trust the CDC. How can we, I guess maybe why do you trust the CDC, and why should people trust the CDC?
I think it all comes down to, it comes down to trusting a person, more so than an organization. I think it's honestly in our blood as Americans to distrust authority. That's one of those things we were founded on: personal liberty and freedom, and and having an appropriate distrust for authority and keeping our leaders in line. I think whenever we see a big organization, we view them as an organization and not the people that make it up. Okay, and that goes for any organization. I think what helps people trust those kind of organizations is to realize that they're people like many of us. They have families. They want this to end. They want this pandemic to end. They want to get out the correct information. There's no conspiracy to trick people, and one of the things that makes it easy for me to trust, as opposed to somebody who doesn't have as much exposure to medicine, is I know some of the most brilliant infectious disease doctors that have the most caring heart for their patients, and they're brilliant. They can interpret the data themselves, and they can analyze it. They're the ones that can correct it. I mean, they're brilliant people in all the different specialties. And these people have hearts that you cannot imagine how big they are. And that's a lot of these people that are at the forefront of this. Their job doesn't end when they go home. I mean, if there's people dying, it's on their mind, especially these ICU doctors, these ICU nurses. It's weighing heavily on them. And if they are frustrated with anyone about not being vaccinated or their distrust in those organizations, it only comes from a place of honestly sadness in their heart in this.
Okay, I've got two more I'll ask quickly, and then Robert, if it's cool, unless you've got something else to say, then I'll say a prayer after. You can kind of say a salutations, and then I'll say a prayer after, and we'll dismiss, if that's okay. So I've got one from Benita Koff that I think will be quick, and then I'll just ask Sybil Matthews' question just right back to back. And if you need me to reiterate, then I can.
Okay.
Benita said she had the Moderna vaccine. Must she wait to get the Moderna vaccine, or can she get the Pfizer since it's FDA approved? And then Sybil Matthews asked, can medications you are on affect the antibodies in your system?
Repeat that last question one more time.
If you're on medications, are there medications that can affect the antibodies in your system?
The second question is actually a little easier. So yes, immunosuppressants could affect that, could affect your immune response. And so that's one of the reasons why, number one, these people would not mount a great immune response if they got COVID. So that highlights the importance of them needing to be vaccinated. Other than that, no medications come to mind that would be in a contraindication or could not be given with the vaccine. But again, if their immunosuppressant is there for a reason, that is, they need it to control whatever disease they have, underlying disease, then that would be up to whoever is the prescriber, who generally would be either a transplant doctor or a rheumatologist who's controlling their inflammatory disease. That would be, probably a better question for that person who's taking care of them. But yes, to some degree, if you're on an immunosuppressant, it could affect your immune response, certainly. The other question is switching Moderna to Pfizer. I will say this, as a general rule, the recommendation is to try to stick with the vaccine that you've had and tolerated. Whatever was in that vaccine, you tolerated it, so generally, why switch? As far as if some people have a strong inclination to switch, I don't know. I think they may have to repeat the series. Do you know anything about that, Dr. Bagwell?
As of my understanding right now, there is no formal third booster recommendations. All kind of comments about it's going to be coming out any day now, but I don't know that those rules have been fully defined. And whether or not if you take Pfizer, should you get the Moderna as a third one, or Moderna, can you get the Pfizer, or can you do the J&J? I don't know. I've not seen any final recommendations for that yet.
So did you say that she'd only had one dose of the Pfizer or Moderna?
No, she's fully vaccinated with Moderna.
Yeah.
And curious about the booster. Could she take the Pfizer? I don't even know if the Moderna
They generally
has a
recommend,
booster yet.
I think the recommendation, if I'm not mistaken, is going to be whichever one you've had and tolerated, to do that one.
Okay.
And that's it. I would just like to end by saying, my love for medicine, really, it does, in more ways than I thought it would in the beginning, and my love for science does point back towards my faith and my belief in a divine creator. We're talking about mRNA, right? DNA. It's a 4-code sequence that codes for everything in your body. It's a 4-digit code is a way to say it. Everything we do with computers, we've copied. It's binary code is what we use, zeros and ones. And so to me, to see that is really is awe-inspiring. There are so many things about the human body and about science that point back to God. And I think that embracing that really, it makes my job fun, and I love getting to explain those things to people.
Hey, let's give them another just thank you, a welcome for being here. Oh, that was great. I mean, we went way over time, but we got such good information. And Robert has said if there are any more questions, you can get them to me and email them to me or text them to me or email them to Robert. We can get that out, and he's more than happy to answer any further questions that we have. But thank you, Dr. Bagwell. Thank you, Dr. Barnes. Thank you for being here tonight. Let's say a prayer, and then we'll be dismissed. Creator God, we love you, and you're just so good to us, and we are so thankful for the many ways that you gift us. And I pray, Lord, as we move forward in faith, as we kind of move through the world, help us to recognize that being afraid and being responsible are not the same thing. And help us to be responsible, and may our faith actually even, may responsibility be a product of our faith, especially as you have gifted us through the years with medical advances and with good doctors, local doctors that we know and trust, that have seen this data and can help us cut through a lot of what we're hearing. We're just so thankful for Jesus. We're so thankful for his sacrifice. And right now, Lord, I pray a special prayer that you will bless everybody that's infected with COVID right now. I pray that you'll bless all the people that are in the ICUs, that you will bring about healing. We trust our doctors, but we know that you are powerful and effective today too. So we ask your healing wind to blow through these hospitals and to blow through this world. And we pray an end to this pandemic. And we just pray an end. We love you and we thank you. And we just ask for more